Meeting again, or yes.
Okay, and what I would ask everybody else to please put their mute on so that we don't hear any back noise while we're doing this. And also, Alan, I'd like to personally thank you for all your participation in putting this presentation together and doing all the audio, video stuff, visual stuff. And that's really we've done some work on it. It's been a lot of fun. But thank you for putting all that together.
My pleasure. It's been great fun.
And it's great to have you, Pete, tonight, and also to have your family and friends. We also have a mystery guest who I'll leave to Pete to introduce at a later time. And I'd like to also welcome some spouses and some of your children and others who are listening to Pete's story tonight. And it's really an amazing story. He has a thoughtful career intertwined with the issues of pregnancy and doctor-patient relations, which is so often the forefront of today's political and ethical discussion. And I wanted to let you know, just before we turn over to the presentation by Pete, that we're not going to do breakout sessions tonight. We will be doing, really, as Pete finishes, we'll do question and answer sessions, because there are so many areas that Pete will be covering that I think will offer a whole lot of questions. And I just had one from my dog just a minute ago. So, but we'll be doing that directly, so there will be no breakout sessions. So it's my pleasure to introduce our classmate, Peter Watson. Dr. Peter Watson, who will be telling the story of his life, which led him to the field of medicine at an early age, and what led him to a career in maternal-fetal medicine as a specialty. Pete's dedication to this field in all aspects will become apparent. He was on the forefront of caring for women and fetuses, and even families in trouble, where often decisions had to be made, many with difficult consequences, and many with continuing stories of grace and hope over a period of 40 years in his career. Pete's story tonight is a personal one involving family and career and the effects of each on each other. I'll give you some just to give you some context before retirement. Peter was involved in over 10,000 deliveries. The wisdom learned and the life experience through the light of his involvement in the lives of so many people has given Pete really a humble outlook on life, as well as a firm commitment, both during his career and after, to supporting the sanctity of the patient and doctor relationship. So Pete, take it away. Tell your story. We really appreciate having you.
Thank you. Thanks to you, John, and thank you, Alan, for helping me to prepare for my talk today. And of course, thank you for Williams College for helping me to develop the tools and determination to turn out to what turned out to be a challenging and ultimately rewarding life. And if I could have the first slide, please. And then the one that follows.
There we go.
Yeah. I don't remember much of my early years, but at about age 5 or so, it all kind of came into focus. And this is me trying to figure out which direction to go in. And it was difficult then, and it still is difficult to a certain extent today. At age 5, I learned that I had 2 mothers. I had a birth mother who gave me up for adoption in New York City in 1945, and an adoptive mother and father who raised me in suburban Philadelphia. And if I could have the next slide. This is my adoptive family. Most of them were profoundly dysfunctional, the immediate adoptive family. I survived in large measure due to the tolerance, the kindness, persistence of members of my extended family. I made it past adolescence thanks to my grandfather, Ed, right there in the middle of the screen, a family physician who had honed his craft during the Spanish Civil War in the epidemic of 1918. My Uncle Hugh, in the back on the right, was Kennedy's PT boat commanding officer in the Pacific, naval hero. And my cousin Michael, who's not in this picture, Michael Cannon, Williams, 63. I knew by age 6 that I wanted to be a doctor. My grandfather was of two minds on the issue. He tried to dissuade me with stories of stress, long hours, and all too many disappointments. On the other hand, he allowed me to carry his medical bag on rounds to see his homebound patients, and he let me help him when he saw patients in his office. He was learned, kind, and had a great sense of humor. I wanted to do what he did, and I wanted to be him. And in 1959, I went to live with my Uncle Hugh and his family in Paris. I'd been obsessed with French since childhood for reasons that didn't become clear until much later. Uncle Hugh was at that time the naval attaché to the U.S. ambassador to France, and I had hoped to continue attending my French high school until college, but those plans fell through in the late summer of 1960 when Uncle Hugh was sent to a command in the Pacific, and I was sent back to Philadelphia. Over the next 3 years, I worked in hospital research labs during the day and as an orderly at night. I loved every minute of it and learned the two most important words in medicine: nurses rule. I became interested in exercise physiology and spent several summers working in Norway at the Work Physiology Institute in Oslo. At the time, I imagined a career as an orthopedic surgeon doing basic muscle research. I began looking at colleges and universities in my junior year in high school. My cousin Michael was at that time a junior at Williams. I spent a winter weekend with him, and no wonder I was hooked. And if I could have the slide, there's a slide having to do with Williams. I was hooked on Williams, no pun intended. I was a pre-med bio major who did well freshman year, succumbed to sophomore slump, and finally did better by my senior year. I enjoyed college, although I learned very early freshman year, for all of those I saw here that actually did make varsity, I knew I wasn't going to make varsity in either soccer or baseball. Friends in the E-flats made me realize I couldn't sing, and they steered me to the Episcopal Church choir. I tried out for a play at the AMT, though, although I was panned for with my reviews of my first role, and I really was terrible, but eventually made cap and bells my sophomore year. I played violin in the Berkshire Symphony Orchestra for my last 2 years and loved it. Most of my courses were in the sciences, but I had as much or more fun in psychology, foreign languages, music, political science, and English lit. For all that enjoyment in other disciplines, I still knew that medicine was going to be my best fit as a career. I was admitted to the six-year MD PhD program in physiology at the University of Pennsylvania. I was ecstatic, and I wanted to call my grandfather, a Penn Med graduate, as soon as I heard the news. Unfortunately, he had just been taken to the hospital with a stroke and never regained consciousness. I drove down to Pennsylvania to see him, talk to him, and hold his hand as he died. I started Penn Med in the fall of 1967 and began 2 years of basic sciences and clinical rotations. I also began to develop a more meaningful relationship with my adoptive father. But early in 1969, when I was in the operating room at the hospital of the University of Pennsylvania, I received the news that my father had suffered a heart attack. I immediately drove to the hospital where he was being taken care of in suburban Philadelphia, but I was too late. He had died in the ambulance on the way to the emergency room. I was as grief-stricken as I'd been with my grandfather's death, but profoundly grateful for the time I'd had with each of them. I began my 2-year exclusive research time at Penn that spring, concerned with my minimal finances after my dad's death, despite a stipend from the physiology department. I was desperate. The Vietnam War was raging, and I decided to enlist in the Naval Reserve to cover my costs through medical and graduate schools. My Uncle Hugh advised against it, but sent the Naval Reserve a personal recommendation. I was accepted, and that summer trained at the Naval Base in DC and then worked as an exercise physiologist at the U.S. Navy Experimental Diving Unit in Durham, North Carolina. I was tasked with designing exercise programs for salvage divers, men who rescued sailors and critical equipment trapped underwater. The programs were similar to those that I had developed in Norway, but the divers were woefully out of shape and hated exercise and hated me for my exercise enthusiasm. Shortly thereafter, though, I noticed a significant number of new divers in the unit. They were extraordinarily fit. They loved my fitness routines and asked for more. One of these new arrivals told me over a beer, he drank, I watched, that he was a SEAL and about to join the North Vietnamese, join the Phoenix program, swimming up North Vietnamese rivers to, among other things, assassinate key village civilians. I had entered Williams as a moderate centrist Republican. However, being taught by Professor Bob Gaudino, having read Professor Fred Schumann, and having been schooled in political action by our classmate Lenny Goldberg, I left Williams as a left-wing, anti-war Democrat. As such, I went to my commanding naval officer and asked him to release me from the Naval Reserve and to send me to the Public Health Service instead. He refused. I took no more money from the Navy, completed my exercise research, and made the programs and test results available to my immediate supervisor. I became a conscientious objector, attended no more Naval Reserve meetings, and received an honorable discharge. If we could do the screen share at this point. The next one, yeah. And full disclosure, the tie was made by my wife. It was our favorite. That's why it was worn at the wedding. On the plus side, that summer of 1969, I met my future wife. I was staying in a house rent-free in DC with a good friend, Williams classmate Dana Stevens, and his fiancée at the time, Jessica Rostow. At a DC bus stop, they came across Harriet Moger, a former Bennington student known to them both, who was then working at ABC News. They invited her to dinner that included me. We sat across from each other that night and never stopped talking. I walked her home and came back to Dana's house to tell him I was going to marry her. After 2 years of a commuter courtship, we were married and decided to settle in Philadelphia. And if you could end the screen share at that point. Late that summer, I began my PhD lab work in earnest. I was excited to collaborate with my thesis advisor, Dr. Saul Weingrad, who had been one of the first to describe how calcium functions within the skeletal muscles to control their contractions. He and I were going to expand his work to study the interaction of sodium and calcium across muscle membranes. Just as we were about to start our work, Dr. Weingrad was offered and accepted an 18-month sabbatical to teach and do research in England. I was left alone to do the work on our joint project. I passed my PhD prelim exams and accumulated enough data to present at the Regional Physiology Society meeting. However, when Dr. Weingrad returned to Penn, he told me I needed at least 2 more years to accumulate enough data to present as a thesis. I thanked him, left his lab, and moved on. I had discovered something during my clinical medicine rotations that was much more compelling than frog muscle contractions. And if we could start screen share, please. And the next one. That was much more compelling right there. Earlier that summer, I returned for my final 2 years of clinical medicine. I started with a rotation on obstetrics and gynecology. I felt in many ways that it was similar to a religious experience. I decided then and there that this is what I was meant to do. OBGYN was a field, and still does, involves aspects of internal medicine, surgery, psychiatry, pediatrics, radiology. And in addition, I felt that the work done in OBGYN was extraordinarily relevant to many of the critical social issues of the day. My personal connection to the issue of adoption was and still is powerful. During my last 2 years at Penn, I took every opportunity to strengthen my understanding of the issues and challenges that OBGYNs faced at that time. I still remember my first experience on the GYN ward. It was filled with women who had developed severe medical complications following abortions, at that time illegal in Pennsylvania, as was the case in most states at the time. Almost all of these procedures were performed by individuals with little or no medical experience in environments that made matters worse and were referred to as back alley abortions. I saw my first patient deaths on that ward. I was tasked with examining one of my back alley abortion patients. She was assigned to me, and each day I entered her findings in her medical records. I presented her case to the staff during daily rounds. Her diagnosis was severe puerperal sepsis, spelled P-U-E-R-P-E-R-A-L. P-U-O-P-E-R-A-L. Sepsis, S-E-P-S-I-S, for those of you who would like to look it up. It's a potentially life-threatening infection of the genital tract, often associated with back alley abortions and less often with spontaneous miscarriages, and occasionally following normal pregnancy and delivery. I remember vividly that patient, how her condition deteriorated during the week as she failed to respond to the few antibiotics that we had for her at that time. She was in her 20s. I felt helpless and overwhelmed as I sat with her each day and watched her die over the course of a week. I took another GYN rotation 2 years later. Roe v. Wade had passed. Abortions were now legal and were performed by trained personnel under sterile conditions. The ward previously filled with patients suffering complications from back alley abortions was now closed. The GYN patients I saw came from the GYN operating room. They were from the recovery rooms following standard operative procedures, which included terminations of pregnancy, many of which I observed and assisted. All the pregnancy termination patients I saw during that month-long rotation recovered well and were discharged home without complications. The only other case of puerperal sepsis over the next 40 years was my last case on my last night of call. I was asked to consult on a patient who came to the hospital in septic shock from puerperal sepsis. She had ruptured membranes spontaneously at home in her 16th week of pregnancy. She began bleeding and continued to leak bloody fluid for several days. She called her midwife, who recommended that she go to the hospital immediately. She declined to do so. A few days later, with rising fever and chills, she finally agreed to come to the hospital, but it was at that point she necessitated an ambulance. When she arrived, she was in shock, progressed to a coma, was treated emergently to clear out the uterine cavity and sent to the intensive care unit for further management. Although this patient eventually recovered consciousness and survived, her recovery lasted for weeks and eventually left her with multiple handicaps and lifelong problems. I graduated from Penn Med in 1973 and began a residency in OBGYN at Colorado General Hospital in Denver, the principal teaching hospital of the University of Colorado Medical Center. My fellow residents, all men, were bright, dedicated, academic, and clinical. Many would go on to teaching and research, while the remainder would begin clinical practice in OBGYN offices throughout the country. It was an exciting time. I felt like for the first time, day in, day out, I was doing what I was meant to do. I was an intern in an OBGYN program that required rotations in related branches of medicine and surgery. I was assigned to the emergency room, the internal medicine wards, the general surgery service, pediatrics, as well as obstetrics and gynecology. The lessons learned during my pediatric rotation were especially rewarding, given that Harriet was pregnant and gave birth to our first son, Eric, Williams 97, at Colorado General Hospital in December 15th, 1974. We were poorly paid as OBGYN residents, and the hours were dangerously long. 36-hour shifts without sleep were not unusual. As working conditions worsened, I was asked by my fellow OBGYN residents to represent them in a collective bargaining effort with the medical center. Our goal was to join with similar residency unions across the country to improve working conditions and to increase compensation for all interns, residents, and fellows in all medical and surgical specialties. I agreed to be one of the union co-leaders to draft a list of negotiable, reasonable demands and present them to administrators and department chairmen. We published our demands and threatened to walk out. Not surprisingly, we were not immediately successful. The other union leader and I were called in to meet our department chairman and both put on probation with the understanding that we and all other members of the union would be fired if we continued our activities. We caved. I did take solace, though, in being offered a teaching and research fellowship in my department 2 years later, which I declined. I also enjoyed seeing our union's demands met quietly, little by little, over the coming years. While in Denver, I was witness to obstetrics becoming a respected profession in and of itself. Obstetrics had not been highly regarded amongst medical specialties in general. My mother always introduced me to her friends and my pastor at church as my son, the cardiologist. As it was a waste of time and effort, I almost never corrected her. And Bill Scott, who probably remembers her, can probably picture the whole scenario. Obstetricians historically were almost all men, a significant percentage of whom were paternalistic and often misogynistic. When I began training in obstetrics, there was no longstanding history of innovation or ongoing exciting research. That all changed in the mid to late 60s and early 70s with, not coincidentally, the dramatic increase of women admitted to medical schools and the increase in the number of women who were nurse practitioners and midwives, almost all women. Most of what I learned about the clinical practice of in medicine in general and OBGYN in specific, and OB in very specific, I learned from women. I was taught by nurses to consult them early and often. I learned anesthetic techniques from female nurse anesthetists and vaginal deliveries from female nurse midwives. I learned critical lessons about grief and loss, primarily from my patients and their partners, from my female medical and nursing colleagues, and from my wife. I learned that when I was working with my patients, it was all about them, not about me. That it would be better to listen more and speak less. That it would be better to ask questions than to jump to conclusions. Good advice for a lifelong desire to improve. The evolution of obstetrics proceeded rapidly from the late 1960s on. In 1970, I listened to my first pregnant patient's abdomen with a modified stethoscope called a fetoscope. Fortunately, the patient I was listening to was near term, and the fetus was large, and the fetal heartbeat, surprise, was audible. If the patient had been less than 20 weeks along at that time, I probably would not have been able to hear anything. By the mid-1970s, electronic fetal monitoring had replaced the fetoscope and continues to do so in successive iterations. At the same time, during the 70s, ultrasound came on the scene to provide a safe alternative to X-rays as a diagnostic modality throughout pregnancy. The first versions gave relatively blurry images, but were useful for confirming fetal position and to rule out twins or triplets without having to worry about harmful effects on either. Late winter in 1977, my last year of my OBGYN residency, Harriet was pregnant again. We could see on ultrasound that our baby was growing appropriately, was surrounded by the expected amount of amniotic fluid, and that was about it, given the technology of the time. During my last 2 years in Denver, I was made aware of the possibility of additional training in maternal-fetal medicine, additional training in maternal-fetal medicine, which was a new subspecialty of OBGYN. Maternal-fetal medicine, also known as MFM, was going to be all about pregnancy, from prior to conception to delivery to postpartum. I'd be expected to follow both mother and fetus, consult with neonatologists and pediatric surgeons, involve internal medicine and surgical support if it fell outside my level of expertise. I deliver babies, operate as needed, make rounds on mothers and newborns, teach and do research. I was completely sold. I accepted a 2-year MFM fellowship in Kentucky at the University of Louisville School of Medicine. I was drawn to that program for its exciting work using ultrasound during pregnancy and treating Rh disease. We moved to Louisville in July of 1977, and I began my MFM training. On August 17th, 1977, Harriet went into labor, went into the hospital, and was examined by her primary doctor. Shortly thereafter, she was completely dilated and about to deliver. I asked a nurse to call her doctor. She said he was too far away and wouldn't be able to get there in time. I asked her to page any and all physician stat. She said, "You're an obstetrician. You deliver the baby." I quickly put on surgical gloves. And if we could start the slides, please. And yeah, I delivered David there on the left, our younger son. He was born with multiple congenital anomalies and had difficulty breathing. The neonatologists arrived and promptly resuscitated him. What followed for him and for Harriet and me as his parents were 2 decades of surgeries and long recoveries. Next slide, please. However, fortunately, with Harriet as his primary advocate and his older brother Eric nearby as his role model and protector, did well. He is now a proud husband and father, a licensed clinical social worker, and sought-after mentor in his chosen field of hospice care. Next slide, or stop the slideshow at this point. Following David's birth, I returned to my work as an MFM fellow. I learned how to help our patients with complex medical and surgical conditions during pregnancy. I also learned how to utilize the ever-improving ultrasound to diagnose and help treat the fetus and communicate with the future parents regarding any neonatal problems that might require treatment after delivery. The most common fetal situation that we treated at that time involved severe Rh disease that required intrauterine transfusions, or at least responded to intrauterine transfusions through the umbilical cord. The coming years featured more advances in intrauterine transfusions and other interventions, including fetal surgeries in utero in conjunction with our pediatric surgical partners. During my fellowship in Kentucky, I performed a number of terminations of pregnancy, with most of these indicated by diagnoses of fetal anomalies, most of them incompatible with life. In Louisville and later in Portland, I never saw a patient who requested a termination of pregnancy frivolously. And many of those patients came from the emergency room and were different from those with fetal anomalies. The patients I saw were invariably serious, conflicted, and saddened by their circumstances. Although I was adopted and previously very conflicted about performing terminations, I became increasingly willing to do so, rather than to pass them on to less concerned colleagues. Unfortunately, Kentucky has now passed a law barring terminations of pregnancy except to save the mother's life or to protect or to prevent serious risk to the pregnant mother's health. After my 2-year fellowship in Louisville, Harriet and I moved to Portland, Oregon, in large measure so that we could enroll David in a nationally recognized oral school for the hearing impaired. I'd accepted a maternal-fetal position at the OBGYN department of Oregon Health Sciences University, also known as OHSU, as an assistant professor in maternal-fetal medicine, tasked with developing Oregon's first community-based maternal-fetal unit at the Emanuel Hospital in Portland. I was asked by Emanuel, in turn, to teach OHSU medical students and residents rotating through the hospital, to recruit MFM partners, to develop an OB research program, and to help Emanuel's pediatrics department recruit neonatologists to set up a neonatal intensive care unit, also known as a NICU or an NICU. All of this, of course, was in competition with similar departments and programs at Oregon Health Sciences University, even though I was a faculty member. I actually thought I could pull it all off, based partly on hubris and mostly on a secret weapon, Dr. Ivan Langley. I had met Ivan at a dinner during my last year in Colorado. I happened to mention that I was interested in this new field of maternal-fetal medicine, but wasn't certain where I'd end up in practice. Ivan took it from there. He was an absolute force of nature who knew everyone in Portland, and everyone knew him. He was a gynecologic oncologist at Emanuel who had used pap smears for cervical cancer for the first time ever in Oregon. He sat me down and mapped out the plan. I was not to worry, he would handle the rest, and he did. Emanuel Hospital in 1979 looked and felt old. It had not had much in the way of renovation since its opening in 1912. All the shared showers on the postpartum floor failed to drain and were either overflowing, toxic, or both. Mice roamed the halls of the delivery suite. Everyone smoked everywhere. The whole hospital needed a makeover, but the situation was extreme for labor, delivery, postpartum, and an NICU had to be built as well. I took copious pictures and produced a slide presentation that documented the need for significant change. We banned smoking and convinced the board to renovate labor, delivery, postpartum in the nursery and to create an NICU. To give the board a better idea of what we needed and what might be feasible, a group of us, including architects, traveled up and down the West Coast to look at the latest OB and pediatric units and NICUs, and a few years later, we had our facility. I recruited an exceptional office manager and an amazing perinatal nurse, and also recruited a neonatologist from OHSU to set up our NICU, a genetic counselor, and a radiologist who decided he preferred ultrasound to X-ray. Establishing Emanuel as a first-class perinatal center was difficult at first. Our office manager shamelessly worked the phones, calling her very extensive who's who list of family, relatives, and friends to promote our new venture. We knew if she called, they would come, and they did. My perinatal nurse and I barnstormed all over rural Oregon, giving seminars on the latest in obstetrics and obstetrical nursing. We encouraged the doctors and nurses we met in those small towns to consider sending their most complicated patients to us, at the very least, as consultations. Memories of those trips on very, very tiny planes still haunt me. I remember runways lit up by pickup trucks in Eastern Oregon, and the times we were buzzed by Air Force jets over Idaho when our pilots got lost at night. It was worth it, though, as little by little, we started to get referrals. My first referral was a woman from farm country north of Portland. She and her husband married at 16, and she became pregnant shortly thereafter. She was referred for her diabetic ketoacidosis, or DKA, a very serious condition when the body is producing large amounts of ketones, blood acids, because it isn't getting enough insulin. I hospitalized her, started fluids and electrolytes, and gave her insulin to slowly bring her blood sugars down as the sugar would be working its way into the system to do the function it was supposed to do. I followed mother and fetus throughout her pregnancy and delivered her at term, vaginally, of a healthy, normal-sized baby. The baby was the first of her 13 babies I delivered, all vaginally. I discussed with her after the third delivery a variety of medical reasons for quitting while she was ahead. I also discussed with her each time after her third the value of not mowing down her neighbors' mailboxes, which seemed to happen early in each pregnancy. She would predictively develop ketoacidosis, become severely dehydrated and confused, crash into mailboxes, her neighbors, and have to make her way to Portland for treatment once again. She declined to quit until her 13th child was born. Getting a particular one, downtown Portland Hospital to send us patients was continuing to be very difficult. And I inadvertently made it more so. I presented a talk on modern management of diabetic pregnancies to a regional meeting and compared the downtown hospital's recently published reports on the subject to other recently published reports. The infants from the downtown hospital had unusually high rates of premature lung disease, and many of them had to be delivered by cesarean section because of their size, all related to high maternal blood sugars. I had overreached, and I took serious flack. As I said to many of you at our 50th reunion panel, moderated by Marty Samuels, may he rest in peace, that in the 1980s, I began to have some of the classic symptoms of burnout. I was anxious, unable to concentrate, depressed, detached, exhausted, and underperforming professionally. Despite a booming business with 5 MFM partners and a supportive neonatal team, I realized I had to take time off and get psychiatric help. I worked with a psychiatrist for a year and was cleared to return to clinical practice. I continued to work with my therapist and met with my partners to discuss my re-entry to the group. As it turned out, they'd already decided I was still too much of a long-term risk for them and voted me out of the partnership. In addition, I could see that almost all of them were suffering from burnout as well. Within a few years, 2 of them decided to leave clinical medicine for good. 1 left the field after trying to commit suicide twice, and 1 died of unexplained causes. At this point, I'd like to take a moment here to acknowledge our classmate, Dr. Hank Grass, who in his later years of the psychiatric practice focused his attention on the critical issue of physician burnout here in Portland and was highly regarded for so doing. Shortly after leaving my group practice, I was approached by an OB nurse at Emmanuel who, well aware of my situation, suggested that we start a practice in perinatal medicine at St. Vincent Hospital, a tertiary care hospital on the west side of Portland. After due diligence with the St. Vincent administration and meetings with the St. Vincent OB providers, we became Northwest Perinatal. We moved into office space of the hospital, began to recruit additional personnel. I was able to build a terrific team that included an office manager, genetic counselor, ultrasonographer, social worker, and several of the best OB nurses in Portland. I started to see patients almost immediately and decided to talk with a neonatologist I'd recruited to Emmanuel to see if they'd be interested in developing a satellite office and a NICU at St. Vincent. They did so, and they were extremely busy within a year. I started recruiting MFMs the next year and began to meet with the St. Vincent OBGYN providers to plan to merge all of our practices into one group to include midwives, MFMs, OBGYNs, genetic counselors. At the beginning, there were only 15 of us, but we agreed to stick together and make it work. Our fortunes went up and down the first few years. We were bought out, we bought ourselves back, but within a few years, we had grown from 15 to 150 providers and named ourselves Women's Healthcare Associates. In the 1990s, shortly before I moved to St. Vincent, the field of maternal-fetal medicine had taken a great leap forward. Ultrasound studies were much improved and could be counted on to detect most significant malformations before 20 weeks gestation. Color Doppler ultrasound studies could image the fetal heart in 3 dimensions, with color indicating the direction of blood flow. Procedures were developed to treat fetal conditions within the gestational sac well before term. Genetic counseling improved significantly as better screens for fetal genetic anomalies were made possible by analyzing samples of maternal blood to extract and analyze the DNA, the fetal DNA contained therein. I made it a habit to recruit MFM partners who'd been recently trained and had developed expertise in a variety of areas that would keep us up to date in diagnosis and treatment. I decided at the same time to become personally more involved in our overall organization and specialized in subjects that I knew well would remain important for our staff and our patients for the rest of my career and beyond. I joined the Hospital Ethics Committee, chaired by Father John Toohey, a PhD ethicist internationally recognized for his clarity, expertise, and compassion. We took on a number of questions over the years that almost always involved how decisions physicians made and their patients made regarding medical care might run counter to the rules of the Catholic Church writ large. We wrote articles on the subject for the Catholic Hospital System newspaper, and in almost all cases, I can remember Father Toohey asking, what do we think would make the most sense here? We would make a decision, write it down, and go from there. Several years later, after I joined the St. Vincent Ethics Committee, Father Toohey asked me to accompany him to a meeting in Seattle. Representatives all up and down the West Coast, ethics committees from the entire Providence system would be gathering to discuss a case that had happened in Phoenix, Arizona, a case that had greatly worried the Providence administration. The case involved a teenager at about 14 weeks gestation with progressive pulmonary hypertension, a very serious condition made worse by pregnancy. The physicians managing her case feared for her life. They asked for the ethics committee at the Catholic hospital to support their recommendation and the patient's request that her pregnancy be terminated immediately to save her life. The Phoenix Hospital Ethics Committee met and agreed to support the physician and patient's recommendation and request. The pregnancy was terminated, the patient's health improved, and she was able to leave the hospital. When the presiding Catholic bishop in Phoenix heard of the case, he excommunicated all Catholic members of the ethics committee, which included a much beloved nun who chaired the committee and was also the hospital's head nurse. The bishop also took away the hospital's designation as a Catholic hospital. Those of us who gathered that day in Seattle discussed what the Providence system would do or should do with a similar situation. But more on that later. During that same time, I joined the Oregon Adoptive Rights Association and worked to find my birth mother, whom I'd been looking for from the time I knew I was adopted. I was aided in my search by a neighbor and very close friend who long ago had found the daughter she had given up for adoption. I hired her lawyer and was about to give up, though, when I received the call that I was waiting for. I learned from my lawyer that my birth mother had died, but that her only child, a daughter, Jenny, was alive and well, living in Charlotte, North Carolina. I was supposed to wait for several days, perhaps a week or more was the traditional recommendation before calling her, but I called her within the first 24 hours. We talked for almost an hour that day and have continued to talk and to get together about every couple of years for the last 25 years. And Jenny is to my left and to my right. I hope you notice the resemblance. We talk with our hands, we love music, and I had found the sister I was looking for almost my entire life. I'd found my birth mother and my sister for questions I had posed for a long time, but for the most part, had been answered. The search for my father has been unsuccessful. I found out that our mother was a U.S. Army nurse. And if I could go back there, thank you, sorry. Was a U.S. Army nurse during World War II. She was fluent in French and served with the troops in North Africa, Italy, and on to France, where I was conceived. French was the language I heard in utero, and I now believe that it explains my obsession since childhood that continues to this day with French language and with chocolate croissant. And as I said, went on and met with my family, my birth family, and Ginny is there in the middle, holding one of her two daughters. And if I remember correctly, the woman to her right is the person who had kept the letters. It was if it's not she, it was the daughter of a trusted sister who kept letters that she sent from the war effort, and letters that were meant to be kept confidential by the sister, and then handed to a trusted daughter, and I believe that is she, but I may be wrong in that. Ginny will have to correct me, and she's here tonight in the presentation. So I'll have to ask her that later, or maybe she may volunteer. But the letters were informative of her war experience, but there was no mention of the father I was searching for. And that, at this point, has been and continues to be unsuccessful. If I could have the next slide, please. On the other hand, my immediate family was thriving. Harriet continued her work as Director of Public Affairs at Reed College. And Eric graduated from Williams in 1997 after being a member of the 1995 national champion soccer team. And this is the trophy that he shared and I was allowed to hold briefly. Our younger son, David, graduated from, and this is Eric's graduation from Williams in 1997. Our younger son, David, if I could have the next slide, please, graduated from Linfield and was honored for his extracurricular volunteer work in his college community. In my last 10 years of practice, I continued to lecture on adoption and to work with organ adoptive rights to see adoption records be open to more legitimate requests. And this last picture is one of the most important Williams-connected baby pictures that I have, which is Eric, 97 to the right, and Araceli, 25, I'm holding, and I, class of 97. No, 67. 97 is Eric. And if I could have the next slide, please. This is a picture of the Williams contingent to the left as you look at it. Wally Bernheimer, my best man at my wedding, and brother-in-law to Harriet, his niece Addie, Williams 15, his wife, Eric's wife Paola, Williams 98, and Araceli, whom we met briefly, who's doing her laundry, will graduate next year as a senior. She's currently a junior. And in the back, Eric, you see, and to his left, and you've got to remember this guy. He is an extraordinary athlete. It's Oliver, my grandson, who's a senior in high school. He's a scratch golfer, was the junior golf champion at Taconic, and we're betting that he goes on to be something special in golf or a sports announcer. Either way, he's bound to be a success. Harriet in front, and then this is, sorry, and I'm on the right as you look at it. And this is, I'm trying to teach my other grandson how to ski. And he actually became a pretty good skier, but now he focuses mainly on tech. and his trumpet. Could I have the next slide, please? And then this was a recent reunion of the entire family with Eric and Paula's family. As you look at the screen on the left, Harriet and I in the middle, and then David and his wife Kelly and their son Caius in a most wonderful time for our 50th wedding anniversary. Thank you. I retired in 2013. And if any of you, by the way, if any of you, that came up really quickly on screen, do you want to leave that a little bit longer, Alan, or?
Yeah, I'll put it back up later. You know what? I'll email the address out to everybody.
Perfect. Okay. And, you know, all of that said, and I've been involved in a number of other community and medical concerns, but I've become most concerned with the issues plaguing this country and the world, specifically the current focus on serious challenges to women's reproductive rights and overall health care. I'm still haunted by memories of the two mothers I treated with puerperal sepsis, the first at the beginning of my career in maternal-fetal medicine and the other at its end. The first mother's life ended in death, and the second mother's life continued with crippling injuries and brain damage. And I worry that there will be many more cases like these left in our country in the wake of the recent Dobbs decision from the Supreme Court. Ironically, amongst developed nations, we have the highest rate per capita income and sadly the highest rate of maternal deaths occurring during pregnancy. Maternal deaths are currently rising in the US, especially in those states with restrictive abortion policies, and loss of physicians who have decided to move from those states elsewhere to provide a full range of healthcare to women. I hope that many of you watching will join Harriet and me and the majority of women and men in this country who believe in protecting women's reproductive health. I am often reminded of that ethics gathering in Seattle many years ago, which concluded with a statement written by Father Toohey. And it said, when faced with a situation of maternal-fetal conflict, we will side with the mother. Talking with you today and looking back at it all, I would choose to do it all over again, minus some of the bumps along the way. And thank you.
Thank you, Pete. It was really a very thoughtful and wonderful presentation, and offers us a lot to think about. And if we have questions, which I hope we have lots of, because when Alan and I visited with Pete in terms of putting this together, we just found that there were just more and more things that came out in terms of his understanding of the relationship between doctor and client. And I hope that we will get some questions. The best thing to do, if you can, is to go to reactions, and you'll see a sign that says hands up. And if you would hit that, then we can call on you. If you can't figure that out, also put your hand up, and I can also call on you if I can see it. But we have two or three full screens here, and so it's hard to pick up everybody. Jenny, it's nice to have you with us tonight, and we hope that you will comment a little bit and give your thoughts on your half brother. And so, as I say, she was the mystery person that we wanted to have introduced. And I have just a question to you, Pete. One of the things that I've seen in terms of our conversations and your presentation tonight, the changes in terms of the tools that you had available to you from the time you started to the time you finished your practice. Yeah. Substantial changes in what you found out. And it seems to me that that's become more and more, you're getting more and more information early on. And I just wondered how that, as you got that additional information, how that really affected your practice and relationship with a patient who was having difficulties. And if you could just sort of comment on that, I'd appreciate it.
Sure, good question. I think in two ways. I think those sorts of improvements, new developments, accelerated incredibly faster than any single physician trained back when I was trained could possibly keep up with it. And I made a point when I hired maternal fetal medicine specialists at St. Vincent to hire them young, in that they were fresh out of their subspecialty training. They were familiar with the new techniques. They were tech savvy, which was not the case for me and for older partners previously. And they took the subspecialty to a whole new direction in a good way, having to do with what turned out to be sort of the forerunner of artificial intelligence, advances in genetics, that was part of that massive increase in terms of the solving and finding functional outlets for the genetic information that we did understand. And then a lot of these new physicians were also interested in building teams, in helping us make sure that we always included not just our physician partners, but the nurses, the midwives, the staff, the ultrasonographers, in decisions, in cases where it was appropriate, and then to educate and inform the staff just on a constant basis with the innovations that the younger practitioners were bringing. And so that's a brief answer to a very good question and could take much longer. But
thank you. Joel, you've got your hand up there.
Yeah, two questions. One is probably rhetorical. Somewhere early on, I think you said, Pete, that you never had a woman offer a frivolous reason for the termination.
yeah.
By your definition and mine as well, I would assume there is no such thing as a frivolous reason. You don't want a baby, you don't want that life-changing event, that's your choice, right? I mean, is there a frivolous reason that you can think of?
That's a fair question. Maybe frivolous wasn't the right word. I don't think I'd ever met a person who wasn't serious about it, who was of two minds, who was oftentimes terrorized by the circumstances that led her to become pregnant. In other cases, furious at pharmaceutical companies for failure of contraception. I mean, it varied. So perhaps frivolous, I'll have to think of coming up with a better term.
And the other question, I think unstated in what you said, is clearly from your own son's congenital issues, I assume that was an enormous impetus in your the direction of your practice and your focus with neonatal stuff.
Yes. Well, the neonatal folks were my partners, the neonatologists, they're pediatricians, and we worked hand in glove. That when I saw on an ultrasound somebody with challenges that David had on an ultrasound, I'd see it on an ultrasound, my first call would go to the neonatologist for a consult. We'd all sit down and talk about what lay ahead. And I think, you know, there's a saying that grief is very much a result of the difference between expectation and reality. And if, you know, somebody builds up their hopes and dreams and so on, all the way to term, only to find, number one, to find a problem extent, and two, to not have a clue at first what to do about it, we at least could give them with all hands on deck support. And I mean, sometimes it was meeting with a psychologist, or meeting in addition with not just the neonatal team, but ongoing pediatrics. I mean, what kind of care was available in the community for the certain conditions. I think the key, the aim in those cases was to get the information to them as soon as possible, and to share the information as soon as possible as to what could be done, and how, and what that meant, and answer questions well ahead of term, for people continuing on to term, to have that, to be able to build up some expertise prior to the event.
Thank you for all that.
Yeah, you're welcome.
Thank you, Joel. Bill Clandaniel.
I've read that the rate of cesarean births has increased dramatically, and I'm curious about your thoughts about that, and also the related question about VBAC, and what your thoughts about that in terms of births.
Okay. Well, prefacing it with I retired almost 12 years ago. That and also that I was focused more on sort of neonatal maternal combinations of problems, but the C-section question with respect to, you were saying that you had read that C-sections have recently increased.
That's my understanding.
It certainly had during my practice over time. For one thing, we were able to identify fetal distress with as ultrasounds, as X-ray, electronic fetal monitoring. As that began to improve in the 70s and 80s and continues on, the information derived from that can oftentimes pick up problems before it becomes acutely awful. So that cesarean sections are done under those circumstances for delivery of a baby prior to it becoming coming out in shock, coming out with difficulty in resuscitating the newborn. So I think a lot of it had to do with earlier diagnosis of problems. There may have been a time when people were saying, I don't want to go through a vaginal birth. I want to just have a cesarean section. That was the interest in that. My sense was that it was beginning to wane in the late 90s and 2000s. I'd be surprised if that's become a thing recently. There was a time when mothers who were interested in pregnancy early on in the development of endocrine infertility specialty, that mothers were having 3, 4, 5 babies before that all got worked out later in the 80s or later in the 70s and early 80s. So cesarean sections rose for a time. Understandably, it's hard to deliver safely babies that, there are 5 or 6 in the womb. We delivered a sextuplet in Denver when I was there as a resident. The chairman came in, who hadn't delivered a baby in about 30 years, came in and said he wanted to take over the case, and you had to know him. He said, I'm going to take over this case. And he pulled them out one by one, and not a single baby survived. And this mother had this huge cesarean section, and it was awful. And that just doesn't happen anymore that I'm aware of. And Yeah. So long question to a very good answer, or long answer to a very good question. Did I cover some of it for you, or?
I was interested in VBAC too. I mean,
Oh, in
this comes
VBAC.
out of my personal experience.
Yeah, I think there's more and more interest in VBAC, or there was when I was just beginning to think about retirement. And the data at that time was supportive, that particularly since cesarean sections were done mostly at that time and continue to be mostly as transverse incisions rather than the big old, cut from stem to stern C-sections that I saw a few of way back when, kind of nightmares, that this much safer way to do a cesarean section, and then to at least discuss the pros and cons of a vaginal delivery. And there's good data on what the percentage risk is, and I couldn't tell you at this point, having been so removed.
It worked well in my case.
Oh, good. Good to hear. Excellent.
Thank you, Bill. Brian Hickman, you've got your hand up.
Yes. Mine's a two-part question.
Sure.
I got the impression, you can correct me from your talk, that there seemed to be some wide variability in the kind of treatment that a woman might get from one medical facility to another, or one doctor's group to another. And I was wondering, with all the stuff that you've worked on, whether best practices are pretty widespread now, or whether there's, and I have a personal reason to ask. My younger daughter is in her 14th week of her first pregnancy, and her blood tests she's in the normal range, but near the edge. And the doctors are saying, geez, we got to look more. And I'm wondering, how do you know you're in the hands of people who really are giving you the best?
Okay. Always get a second opinion and always ask around for who's the most knowledgeable. I mean, I think that's good advice for any situation medically. So I would say in the early, certainly in the 60s and early 70s, medicine was mostly about, I think this will work. I think I lost Alan or John. I lost a person. Hi, Jenny. I lost the person I was talking to.
Oh, Brian Hickman.
Brian Hickman. Yeah.
Yep.
Okay. Can you or can somebody connect me up with Brian?
He's on the. Can you see him there? Brian, wave if you would.
Can you hear me, Brian?
Speak up.
Yes, I hear you.
Okay. So at that time, it was, I learned from person who taught me, and this person taught me, and so on and so forth, back 4 generations. And then best practices started to come into play late, to my experience, late 80s or late 70s and 80s. And now it's all about developing good protocols with good follow-up. And, when you present a case, the first thing that we asked in at least the last 10 or 15 years of my practice was, okay, what's your data? What are the follow-up studies showing? Do we have a substantive reason for continuing along this course? And I think that depending where you live, just out of curiosity, where would be the hospital of delivery? What community?
She's just moving from the middle of Washington, D.C. to Arlington, Virginia, but the capital area.
Capital area. And, we could probably pick 4 or 5 really solid hospitals for obstetrics and gynecology in the DC area that maintain very, very high standards with respect to accepted protocols and follow-up. And but I'd ask around, who is recently trained at one of those hospitals, or check to see if there's somebody there who specializes in the concerns that your daughter has and her and what she's been showing in her laboratory findings. That is there somebody there who in one of those facilities who specializes in that particular problem?
Yeah, well, thank you.
You bet. Good luck.
Thanks, Brian. We've got time for 2 more questions, and Ed Wing, you're up next, and then Alan, and I think that will finish us up. Yep, Susan. It's going to be Susan. Ed, go ahead.
So Pete, that was a wonderful talk. I really enjoyed that. And
Ed,
I enjoyed your comments about nurses. They do rule. I've served as an orderly for a summer the way you did, and they're just essential to the practice of medicine.
well
But
said.
I wanted to comment about burnout,
Yeah.
which is something which I was under tremendous stress and had to get help at one point.
Oh,
Medicine's hard, and I've heard that one of the reasons is that doctors are not only altruistic. That was my wife dropping something. We're altruistic, but we're also perfectionists.
yeah.
The combination is very tough to deal with, especially if doctors make mistakes or
Yeah.
feel they're not quite doing the right thing. It's very, very difficult. And I'll just
Yep.
make one other final comment. When I was a medical student, I saw a woman, a middle-class woman, coming in with a septic abortion,
Yeah.
who turned out to have tetanus.
Yes.
She was, had a severely infected uterus and had tetanus itself. So it was an awful, awful time. I
And it
really-
is. Yeah.
Yeah.
It's just, yeah. Well said.
So those are comments, not questions, really.
Yeah.
Great,
Thanks,
great
Ed.
talk.
Good comments.
Enjoyed
That's, you honor me.
Now, I think we have one more here, and it's not from Alan, but it's from Susan.
Susan.
Hi, and mine's more of a comment, but thank you so much, Pete. This has been wonderful. And as most of you know, I also graduated in 1967, and our careers paralleled in that I worked in women's reproductive health largely for 50 years, but I did that as a medical anthropologist. So I was looking at how women from different cultures experience pregnancy and childbirth, how we improve that. What I wanted, and right now, as you know, I'm working with the National Academies of Science on what I'm calling the unintended consequences of the Dobbs decision, all the terrible things that are happening not only to pregnant women, but to all women of literally from age 7 to 70 who are being denied cancer treatments, they're being denied treatments for arthritis, they're being denied anything that might be an abortifacient if they're of reproductive age, even if they're not pregnant. But what I wanted to say to you is that in 50 years of working with obstetricians, there were so few.
What a wonderful person. Oh, here we go. Now you're back.
Okay.
Oh, did we?
Did you lose me?
Yes, we did.
I was going to say that in 50 years of working with obstetricians, there were so few like you, Pete. There were so few who listened to women, who listened to nurses, who looked at the whole person. And I just want to thank you really on behalf of all of the women that you helped for being that kind of obstetrician.
Thank you.
Well, thank you, everybody, for coming. Thank you, Pete.
We learned it from Bob Gaudino.
Yeah.
I thank you for the presentation. It was also nice to have really 3 generations of Watsons with us tonight. And also, Jenny, to have you here as well, because you were certainly part of the story and a wonderful continuation of a story that Pete had been looking for all of his life.
And to Harry.
And I just thank you for joining in with us.
Thank
Right now, we're going to be taking a little bit of a break until the beginning of the new year. But your crew who's been working on Zoom has got some new ideas and will be moving on and be presenting that to you by the first of the year. So thank you all for participating in this. It's fantastic to have always over 35 or 40 classmates here with us to talk and to learn about each other. And I've just found it, and I know a lot of you have, is being really genuinely a beautiful time to learn about each other and to have an opportunity to really understand and to know each other's lives a little bit better. And I think at this point in life, that's a real gift and a real gift that we all receive. So thank you all for being part of this. And
Thank you.
good
Thank you
night.
so much for making it happen. Thank you so much for making it happen.
Yeah, thank you, John.
Well,
Thanks, Peter.
it's been a great crew, and there's 6 of us who've been doing this, and we really have enjoyed it. And it's just great to have presenters like Peter and like all of the ones that are here tonight that have presented already. So we look forward to hearing from more of you. Thank you all.
Thank you.
Good night.
Thank you, everyone.
Yeah.
Hi, Jenny.
Hi.
Hi.
I think we got some of the Watsons still here. Pete,
Yep,
Pete,
we do.
no, Pete left us.
Yeah.
So Jenny, this is Alan Stern. I've been talking, John Hufnagel and I've been talking with Pete a lot. And in preparation for this talk, but it looks like he already signed off. So,
Yeah, he did.
yeah. But you didn't know him when he was at Williams, obviously, because you didn't meet him until later. So
That's right. That's right. It was a great surprise.
yeah,
Yeah.
it was a heck of a story that John and I have been on the ride with Pete. So
We just,
yeah, very moving.
it's nice. I know how much it means to him to have you in his life, and I think that's a wonderful thing.
Yeah. Well, the feeling's mutual, but I told
That's
him he
good.
was way too late joining my life after I'd had my 4 children. I said I could have used you way before that. But anyway.
Yeah, so we could have made this whole session just about your story, your and
Right.
Pete's story.
Yeah.
It's that fascinating.
Yeah, it is. It is quite a shock.
Yeah. So how old were you when you found out about Pete?
I believe I was 30. Let's see. No. Yeah. About 34.
And had
And,
no clue that you had a half brother.
No. My mother said nothing. Our mother said nothing.
Yeah. Yeah.
Yeah, except to one sister, and then that sister told her daughter, and they were not to tell me unless I asked first. So then when Pete contacted me, I didn't know to call them, but I thought maybe they would know something. And so that's when they told me that it was true. Yeah.
Well, it was nice to meet you tonight. And
Yeah, it was good to meet you.
I know we certainly enjoyed having you with us. So,
Yeah, it was wonderful.
Alan, nice job tonight, as
Yep.
always.
You
And
too.
we'll sign off. All right.
All right.
Good to see you.
Oops, I guess I need to stop the recording. I need to stop the recording, don't I?
Yes.
Before we
Alan,
both.
stop the recording.
All right.
And edit.
Okay.
All right. Take care.
Take care. Good night.
Nighty night.